Hello everybody, and welcome to the Tuesday edition of Video Clips. And we are loving this video stream thing that we're doing here in the office because it lets people literally all over the world participate in things that go on here. So some of you might have been involved in watching our dinner presentation. This is what we do at least once a month in the office to show new people about informed decision making. Unfortunately, we can't feed you the food long distance, but we can give you the same great information, and the people remote were able to ask questions. It really worked out well. So this Saturday, if you're a member of Wellness Form Health, I'm teaching how to get started, which is sort of the 4-hour boot camp on how to get this off the ground, this new way of looking at health and medicine and eating differently and all that sort of thing. So all you have to do is contact the office and we'll be happy. It's if you're a member, it's free to get you all set up and let you know how you can watch this on your phone or your netbook or tablet or computer. The other thing is we're just 3 weeks away from the start of the Diet and Lifestyle Intervention course. The summer version of it features the celebrity instructors like Dr. Esselstyn, Dr. Barnard, Dr. Goldhammer, Dr. Schultz, Dr. Moss, spending Wednesday evening in a live and interactive setting with these guys is an experience I promise you will love and enjoy. I've been hosting this series for, oh my gosh, it's got to be 5 or 6 years now. I still learn something new every single time I'm on the phone with these guys, because there's, some people are so smart they don't even know everything that they know, if that makes any sense. So anyway, if you want to join us for some, I think, life-changing information, I mean, if you're a practitioner, this is going to change your practice, and if you're a consumer, this is going to change your whole life in some pretty profound ways. All right, I've got a couple things to talk about today, and the first one is most patients with confirmed Lyme disease recover after taking antibiotics, but some patients, as many as 20% of them, continue to have symptoms that include fatigue, musculoskeletal pain, sleep disturbance, and cognitive decline. Longer-term treatment of antibiotics is often recommended for these patients, but several randomized placebo-controlled studies have shown that long-term antibiotic therapy did not result in better clinical outcomes or reductions in symptoms. 2 trials showed that there was no difference between oral or intravenous antibiotic treatment and placebo for relieving symptoms associated with Lyme in patients with a confirmed diagnosis. Now, one of the reasons may be that in these studies, for most of these patients, testing did not show that there was evidence of lingering infection. Unfortunately, this type of information hasn't stopped the prescribing of long-term antibiotic therapy for people who at one time had a confirmed diagnosis, or for people who have chronic symptoms similar to those experienced by Lyme patients, such as the fatigue and cognitive decline, but have never had a firm Lyme diagnosis based on any reliable testing method. Well, a new study looked at this issue, and it's very interesting because it included both patients with confirmed Lyme diagnosis, but even more of them who did not have a confirmed diagnosis. The unconfirmed patients had symptoms that were attributed to Lyme disease based on positive results from tests that are not considered reliable. The problem with these tests, they're antibody tests, and the problem with them is that they have a high rate of false positive for many reasons, including the fact that antibody count can remain high a long, long time after an infection has actually been cleared. All patients in the trial were given intravenous antibiotics for 2 weeks, and then 12 weeks where they were randomized to get antibiotics or placebo. During the 2 weeks of antibiotics preceding the actual trial, the 12-week period, 131 patients reported at least one side effect, with the most common being rash and diarrhea. During the 12 months of treatment, 205 patients reported at least one adverse event, with 9 patients having serious side effects and 19 who had side effects serious enough that they decided to drop out of the trial. Side effects included during this phase included nausea, photosensitivity, and diarrhea. But here's the problem. The study showed that patients taking the antibiotics did not show more improvement in symptoms or health-related quality of life than those taking placebo. In other words, no benefit, just about half of the patients had harm. In an editorial about the study, experts acknowledge that some critics might claim that 12 weeks of antibiotic therapy wasn't enough to achieve a result. But they say, and it is true, antibiotics usually work pretty quickly when prescribed appropriately, which is for confirmed infection, so it is not very likely that continued antibiotic therapy would have changed the outcomes. The authors reference a study showing long-term mental and physical outcomes for patients with confirmed Lyme disease who don't receive long-term therapy are about the same as those in the general population. The diagnosis of Lyme disease without reliable test results is common in some types of practices, particularly those advertising themselves as holistic or integrative. We've had many members with such a diagnosis, I would even put air quotes around that, who haven't experienced resolution of their symptoms, but instead have actually experienced worsening health because antibiotics are really hard on the system. We've had people in here who've been on antibiotics for 2+ years in response to an unconfirmed diagnosis. My personal opinion, based on research like what I'm reporting here, my own experience, is that the diagnosis of Lyme in many patients is inaccurate, and that patients suffering from nebulous symptoms such as fatigue and muscle pain have other conditions which are not being addressed by their Lyme-focused doctors. So the bottom line is that short-term antibiotic treatment is effective for patients with a confirmed diagnosis of Lyme disease. Long-term antibiotic treatment doesn't change outcomes. And for those who don't have a confirmed Lyme diagnosis, they are not candidates for treatment at all. So, let's go on to the next topic, a little bit disturbing here. I have some sympathy for oncologists. Let me start by saying that. They regularly have to deliver bad news to patients, and that can't be fun. In addition to delivering the bad news, they have to engage in conversations about treatment options and assist in decision-making with patients who are usually and understandably in a highly emotional state. Well, effectively dealing with cancer patients requires both very good communication skills and empathy. The problem, according to some experts, is that most practicing oncologists have never had formal training that prepares them for empathic communication with cancer patients. This lack of training is most likely a contributing factor to the results of a 2012 study that looked at medical records for over 1,200 patients with metastatic lung or colorectal cancer. The researchers reported that 69% of patients with lung cancer, 81% of patients with colon cancer were not aware that the chemotherapy treatments they were receiving were not likely to cure their cancer. They wrote, quote, "Many patients receiving chemotherapy for incurable cancers may not understand that chemotherapy is unlikely to be curative, which could compromise their ability to make informed treatment decisions that are consonant with their preferences." A recent article posted on Medscape provided some advice from experts on physician communications about how doctors could do better. Dr. Catherine Pollack says that doctors often do not pick up on patient emotions during conversations about care. A patient may ask what sounds like a medical question, but if you're reading between the lines, really is an expression of fear about outcomes. Instead of picking up on this, doctors provide medical answers, and sometimes that's perceived by the patient as discouraging him or her from talking about emotions, anger, and fears. Responding with "it sounds like you're angry or scared" would be better, but instead a lot of doctors will just start talking about tumor sizes and setting treatment schedules. Another issue that affects communication is the physician's own emotional state. Sometimes doctors are uncomfortable and they just want to get the conversation over with as quickly as possible, or to remain emotionally detached. Developing self-awareness and mindfulness can be helpful, which are distinctly different skills from knowing the right thing to say. Training resources are available for doctors, and I looked at some of these and they're interesting. Vital Talk offers online videos, facilitated courses, and even an app that sends tips daily to subscribers. MD Anderson has a program and a website that includes videos and other resources for helping physicians to learn better communication skills. One that seems really promising is the Patient-Centered Outcomes Research Institute. This organization is doing a clinical trial this fall that will include 100 oncologists, half of whom will get some feedback on conversations that take place during clinic visits. And the goal is to see if providing that feedback results in better outcomes as compared to controls who will not get that type of feedback. I will tell you that during our 2 decades of being in business, we've heard a lot of stories from members with cancer about some fairly horrific interactions with oncologists who were arrogant, dismissive, argumentative, short, curt, and just not nice. This article, I guess, sheds some light on why doctors act this way. They're not bad people in many cases. They're just well-intentioned people who continuously find themselves in bad situations. While this article may help us to feel a little more sympathetic, the more important point is that it doesn't change the fact that every day in oncology offices, patients are given unrealistic and untruthful information that overpromises what treatment can deliver. And so, as was quoted in the study, one of the studies I quoted, this means patients can't possibly make informed decisions. So I think objective risk-benefit analyses for cancer patients are just imperative. It can save lives when people refuse treatments that can hurt them, and it can also result in patients spending their time and energy in looking into better options. One of the things that I hear in my office all the time is, if I knew then what I know now, I never would have gone down this path. And it's bad enough to hear that about taking medication for blood pressure or diabetes, but many times for cancer patients, the decisions to embark on a particular type of therapy that can't help you will likely hurt you. And by the time you find out that that's the case, your cancer's progressing, your health has worsened as a result of the treatment, and what would have been good options many months ago may not be as effective now. So I've always emphasized with cancer patients, my advice has always been, take a little time, investigate before you do something to make sure that it's really the right thing for you to do. All right, that's all for today. As usual, pass this on to anybody who you think might enjoy watching it, and I'll be back to you on Thursday with more news.